Hello everyone. Let's suppose I have a 50-year-old patient who presents with something that looks like jaundice. What should I do? Well, the first thing I would do is check if this is really jaundice, and the best way to do that is to take a look at the patient's sclera, because the sclera becomes yellowish at lower concentrations of bilirubin than the skin, meaning if the sclera is not yellow, this is not jaundice, because the skin is not very reliable. It can look jaundice when it's actually not, especially if the patient is dehydrated or severely anemic, or if the lining is not very good, right? But okay, let's suppose that our patient really is jaundiced. What next? I would try to determine if they are so sick that their condition requires immediate resuscitation. In other words, I would check their vital signs. So I would talk to the patient to assess their level of consciousness and check their body temperature, blood pressure, heart rate, and respiratory rate. If all of this is within acceptable limits, then I know that I have time to think. And when trying to determine the most probable cause of jaundice, it's best to follow the metabolic pathway of bilirubin. Bilirubin is formed by the breakdown of red blood cells and hemoglobin, more specifically heme, first into biliverdin, then into unconjugated or indirect bilirubin. The problem with indirect bilirubin is that it's very poorly water soluble. So in order to be eliminated from the system, first it has to be conjugated, meaning bound to more water soluble compounds. This happens in hepatocytes, in the liver. Next, it has to be excreted into the bile ducts and then delivered to the intestine. So you can already see all the potential problems that can happen along this path. If the liver is damaged by inflammation, poor perfusion, or medications, every one of these intricate steps in the metabolic pathway of bilirubin can be disrupted, ranging from the uptake of bilirubin into the hepatocytes, the conjugation, and excretion into the bile, not to mention the passage through the biliary ducts to the intestine. So, what could cause inflammation in the liver? Obviously, infections. Again, we come back to the vital signs. Elevated body temperature or fever, right, usually indicates some sort of infection. And other vital signs show us if the patient is septic or not. So if the patient does have a fever, but they are not septic, the first thing that I will suspect is viral hepatitis. And I will ask the patient about specific risk factors for viral hepatitis, like unprotected sex sometime in the last 6 months, intravenous drug use, and of course, travel history. In industrialized countries in Europe and North America, hepatitis B and C are predominant, but hepatitis A is making a comeback in certain risk groups, and hepatitis A is still endemic in many parts of the world, especially areas with poor sanitation. I would also ask about symptoms of viral hepatitis like nausea, anorexia, malaise, maybe abdominal pain, especially in the right upper quadrant. Now, this pain should not be very severe. It shouldn't be colicky or unbearable. If this is present, I would suspect probably biliary obstruction. We'll get to that. Nevertheless, many patients with viral hepatitis do feel at least some sort of discomfort in their abdomen, especially in the right upper quadrant. In textbooks, you may find that all sorts of viruses like herpes viruses, Epstein-Barr, CMV can also cause hepatitis, and they do affect the liver, that is true, but they will rarely present with overt jaundice. Okay, so much about viral hepatitis. What if the patient has a fever and they are also septic? Well then, first I would suspect bacterial cholangitis, especially if there is right upper quadrant pain present, right? Bacterial cholangitis is a bacterial infection of the biliary tract. It usually happens as a consequence of obstruction, usually with gallstones. So I would ask the patient about history of gallstones and surgery involving the biliary tract, because post-surgical strictures can also cause obstruction and then infection. But please keep in mind, just because the patient is septic and jaundiced, this doesn't mean the primary problem is in the biliary tract. Of course, you will check that, by all means. But any kind of sepsis, staphylococcal sepsis for example, can also cause jaundice. Remember that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. This organ dysfunction can include liver dysfunction as well. So if the patient doesn't have severe pain in the right upper quadrant, but they are septic and jaundiced, be very careful and consider other potential causes of sepsis. I see that many doctors often suspect leptospirosis when they see a jaundiced septic patient. In industrialized countries, please be very careful with this, because in order to have severe leptospirosis, you have to have significant exposure to leptospira, meaning you will usually have to be exposed to water contaminated with animal feces and urine. Walking around the park and seeing a rat somewhere does not count. So again, in industrialized countries, when you see a jaundiced febrile patient, consider all possible sources of sepsis, but if they don't have a significant exposure to leptospira, it's probably not leptospirosis. Okay, so much about infections. There are other inflammatory conditions that don't have anything to do with infections, like autoimmune hepatitis, that can cause jaundice, of course, but this is much less common than the infections that I just discussed. So if you exclude all of that, or if your patient has a convincing personal or family history of autoimmune disorders, then okay, you will consider autoimmune hepatitis, but it's really rare. In addition to inflammation, I also mentioned medications as possible cause of liver damage. So ask your patient if they started any new drug sometime in the last couple of months. Theoretically, any drug can cause an idiosyncratic reaction and cause severe liver damage, but usually in Western industrialized countries, by far the most common toxin that causes liver damage is alcohol. Both acute alcoholic hepatitis and decompensated liver cirrhosis require heavy alcohol consumption over the course of many years. Now, patients who already have cirrhosis, most of the time they will already know that they have it. Plus, you will see the typical symptoms of cirrhosis like ascites, edema, muscle wasting, pulmonary edema, distended paraumbilical veins, spider angioma. So it should be quite obvious that the patient has cirrhosis. Talking about drugs and toxins, paracetamol overdose is common in industrialized countries. There are also some herbal supplements that can cause severe liver damage. In my area, what is quite common is mushroom poisoning. Every fall we see this. Patient gets very sick shortly after ingesting mushrooms, and then they develop signs of liver damage and unfortunately often also liver failure. There are also many congenital metabolic problems that can cause liver damage. It's impossible to cover them all in this short lecture, but most of the time your patient's diagnosis will fall into one of these categories. I would like to go back to biliary obstruction for a minute. I mentioned gallstones and post-surgical strictures as potential causes of biliary obstruction, and this will usually present with pain, among other things. But painless jaundice, remember this, painless jaundice is usually bad news. If you take a look at the anatomy here, it's easy to guess what kind of tumors can cause biliary obstruction. Usually this is cholangiocarcinoma and pancreatic cancer. Both very invasive types of cancer, very difficult to treat, and they carry a very poor prognosis. But okay, let's suppose that you can't find any signs of liver disease or biliary disease besides jaundice, of course. In that case, you have to also consider hemolysis as the cause of your patient's jaundice. What could cause hemolysis? Well, any number of causes, and again, it's impossible to cover them all in 10 minutes, but if you know what you're doing, you can at least determine the type of disorder you are probably dealing with. First, there are congenital abnormalities to the structure of hemoglobin and red blood cells that predispose them to a faster breakdown. Next, there are acquired hemolytic anemias that can be immune-mediated and non-immune mediated. And this is why whenever we see a patient with possible hemolytic anemia and we don't know the cause, we always include a Coombs test in our diagnostic workup to screen for antibodies that bind to red blood cells. Some causes of hemolysis need a lot of time before the patient is actually anemic and before they start to experience any symptoms, while other causes progress brutally fast and the patient looks sick right from the start, because in rapidly progressing hemolytic anemias, all of a sudden there is a huge shortage of red blood cells and hemoglobin, and there is not enough hemoglobin to deliver enough oxygen to all the cells in the system. The body tries to compensate for this by speeding up the circulation of blood and by improving oxygenation. So clinically, you may notice that your patient's heart rate is abnormally high and that their respiratory rate is also increased. If they are severely anemic, they will feel fatigue, weakness, in extreme cases maybe even shortness of breath and chest pain. In life-threatening emergencies like TTP or falciparum malaria, there may also be signs of encephalopathy, so signs of brain dysfunction. So once again, it's paramount that you assess your patient's vital signs. Now, another thing that can help you in finding the cause of hemolytic anemia is the fact that patients who do have congenital abnormalities to the structure of hemoglobin or red blood cells may already know that they have a specific disorder or they have a family member who does. So ask them about this, even for immune-mediated anemias, right? Immune-mediated anemia can be triggered by pre-existing autoimmune disease, and autoimmune disorders like company. Where there is one, there could be another. So again, ask about personal and family history of autoimmune disorders. Autoimmune hemolytic anemia can be triggered by a reaction to a recent infection or a new drug. So just like with liver disease, ask about new medications that were started sometime in the last couple of months and ask about the recent fever. Okay, now that you've taken your patient's history and you've examined them, what kind of diagnostic test should you order? Well, for starters, when dealing with jaundice, the most important test is the level of bilirubin and what kind of bilirubin you are dealing with. If it's unconjugated bilirubin that is predominant in your patient's bloodstream, there are two things you need to think about. Number one, of course, hemolysis. In that case, you will look for other signs and symptoms of hemolytic anemia, and you will look for other laboratory abnormalities that we are about to discuss to support this diagnosis. However, if you can only see mild jaundice and mildly elevated unconjugated bilirubin, but your patient has no other symptoms and signs of hemolytic anemia or liver disease, this is probably one of the congenital abnormalities in the metabolism of bilirubin, most likely Gilbert syndrome. These patients will have no serious symptoms, they will just get mildly jaundiced, usually in the times of stress or infection, and besides being scary the first time you see it, this condition is completely benign and no harm will come to your patient. Okay, so much about unconjugated bilirubin. If both unconjugated and conjugated bilirubin are elevated, with conjugated bilirubin being predominant, this is either liver disease or some sort of biliary obstruction, and we will use other tests to narrow down the possibilities. In addition to bilirubin, you will also order the levels of ALT and AST, two enzymes that are present in hepatocytes, and if hepatocytes get damaged, these enzymes leak into the bloodstream. In acute viral hepatitis, the levels of ALT and AST are usually very high, hundreds if not thousands of units per liter. In chronic hepatitis like hepatitis C, they tend to be less impressive. Please remember that in viral hepatitis, ALT is usually much higher than AST, while in alcoholic hepatitis, it's the exact opposite. AST should be higher than ALT. In addition to these two, you will usually order the levels of alkaline phosphatase, ALP, another enzyme that is present in the epithelium of bile ducts and in the liver. But the problem with this enzyme is that a similar enzyme is also found in the bone. So if you want to make sure that this elevated ALP in our patient's blood really originates from the liver, we want to order the levels of GGT as well, gamma glutenyl transferase, another enzyme that is found in the biliary system and the liver. So if both of these enzymes are elevated, then we can be certain that we are dealing with some sort of liver or biliary disease. In addition to these markers of cell damage, of liver and biliary damage, right, we also want to assess the remaining synthetic function of the liver. And we do that by measuring the levels of albumin, a protein that is synthesized in the liver, of course, and INR, a value that is directly dependent on the concentration of prothrombin, a coagulation factor synthesized again in the liver. In most cases of viral hepatitis, the synthetic function of the liver will be more or less intact. Now, of course, there are rare cases of fulminant hepatitis, which is a life-threatening condition, and in fulminant hepatitis, the synthetic function of the liver is severely impaired. But again, fortunately, this is rare. In cirrhosis, you will usually see a diminished synthetic function of the liver. And let's not forget that in every patient with jaundice, you should also order a complete blood count with differential and, if possible, a peripheral blood smear. In the CBC, you may find leukocytosis with neutrophilia in patients with severe pain or in septic patients with any kind of sepsis, including cholangitis. You may also find signs of anemia in hemolytic anemias, right? An abnormally low concentration of red blood cells and an abnormally low concentration of hemoglobin. With some analyzers, you may even find an elevated number of reticulocytes, immature forms of red blood cells that get mobilized in response to hemolytic anemia. But what is especially useful here is the peripheral blood smear, because some types of congenital abnormalities to the structure of hemoglobin and red blood cells result in distinctive shapes of these red blood cells. For example, sickle cell anemia is not called like that for nothing, right? Even in immune-mediated anemias, you may find clumping of red blood cells. In non-immune-mediated hemolytic anemias like TTP, you may find these damaged red blood cells that literally look like they've been cut by a knife. All in all, this widely available, inexpensive, and simple test can really help you a lot. So please remember to order a peripheral blood smear in addition to a complete blood count with differential if it is available, of course. Regarding viral hepatitis, in most hospitals, you should be able to order serology for viral hepatitis, maybe even PCR, and you will have your diagnosis in no time. For autoimmune hepatitis, it depends, but usually you will not order tests for autoimmune hepatitis right away. Besides, if you go down that path, you will usually consult a specialist. If you suspect biliary obstruction as the cause of your patient's jaundice, of course you will order imaging. Already with abdominal ultrasound, you will usually get a good view of the liver and of the biliary tract. Now, of course, the drawback of ultrasound is that it requires a lot of skill. I personally don't have it, so I always consult my radiologist. And if your patient is in a lot of pain, or if they are bloated, if they have a lot of gas in their intestines, you may not be able to get a good view of the liver. If you suspect malignancy like cholangiocarcinoma or pancreatic cancer as the cause of your patient's biliary obstruction, it's better to order an abdominal CT scan. You will get a much better view of these structures. In some cases, you may have to consult a specialist for more advanced imaging modalities because just because you can't see an obstruction in the common bile duct, this doesn't mean that the problem isn't in the biliary system. Certain autoimmune conditions can affect smaller bile ducts, and this will not be visible with abdominal ultrasound or a CT scan. I hope that this helps. Of course, we didn't cover every single possible cause of jaundice out there, but with this framework, you should be able to find the cause in the vast majority of cases. If you want to learn more about life-threatening infections like sepsis and central nervous system infections, I suggest you take a look at my free online course. The link is right there in the description. Thank you for watching, good luck out there, and take care.